Welcome to my channel.
Today's our topic of discussion is CA gallbladder. So the objectives of today's videos is the etiology, pathophysiology, history and physical examination, the evaluation, differentials, management and the complication. What are the risk factors of the CA gallbladder? The patient having the gallbladder polyps, the congenital biliary cyst, abnormal pancreaticobiliary anatomy, the chronic cholecystitis, asymptomatic carrier of the Salmonella typhi and Helicobacter, the carcinogens, the methyl dopa, isoniazid, work exposure carcinogens like methyl cellulose, antradone, the lifestyles, cigarette smoking, obesity, high carbohydrate intake, chronic primary sclerosing cholangitis, and inflammatory bowel disease. Do you know what is the pathophysiology behind the CA gallbladder? Basically, the chronic inflammation of the bile duct tissues accumulate the successive genomic mutations that leads to the malignant transformation. The mutated oncogenes for CA gallbladder are the KRAS and the tumor suppressor beta-catenin. Now come to the types of the CA gallbladder. The most common type is adenocarcinomas. These are present in 90% of the patient with the CA gallbladder. The squamous cell type, it is present in the 20 to 30% of cases. Adenosquamous cell, and it's basically present in 3 to 4% of patients. And the papillary carcinoma, it is very rare carcinoma of the gallbladder. How the patient will present to you with the CA gallbladder? He or she will present with the right upper quadrant pain, jaundice, anorexia, weight loss, nausea and vomiting, bloating, and lump in abdomen. But if the patient have a biliary obstruction, it will lead to jaundice, clay colored stools, cola colored urine, and the skin pruritus. So, gallbladder cancer detection is often occurs as an incidental finding on imaging or after the surgical procedure. Early stage gallbladder cancer is commonly discovered after the cholecystectomy. What are the findings on the physical examination? Jaundice will be positive. Palpable mass in the right upper quadrant, which is a cross-Weiser sign. The periumbilical lymphadenopathy will be positive. Sister Mary Josephson notes. Left supraclavicular lymphadenopathy, which shows not. Pelvic seeding will be positive. Palpable mass will felt on the digital rectal examination, that is known as the Blummer shelf. What are the differentials in the patients presenting with the right upper quadrant pain and the similar signs and symptoms? These are the acalculous cholecystitis, acalculous cholecystopathy, ampullary carcinoma, the bile duct structure, the bile duct tumor, the biliary colic, the biliary disease, the biliary obstruction, cholangitis, and the cholecystitis. So, what are the investigations do we need to diagnose the CA gallbladder? The most important is the tumor marker CA19-9 or CEA levels, but these are the not initial investigations. The most important and the most initial investigations are the LFTs, blood urea nitrogen, and the CBC. CBC will reveal the anemia and its indicator of the more advanced disease. Blood urea nitrogen, creatinine, and the urine analysis assess the kidney function prior to performing a CT scan for the further investigation. LFTs, elevated alkaline phosphatase, and the bilirubin levels are often found in the more advanced disease where the tumor is causing the biliary obstruction. The most important investigation is ultrasonography. It's a standard initial study in the patient with the right upper quadrant pain, and mass can be identified in ultrasonography in 50 to 75% of cases, and it is also used to differentiate between the benign and the malignant conditions. Another investigation which is also important in staging and grading of CA gallbladder is CT scan. Basically, CT scan will reveal the GB masses, thickening of the gallbladder wall, it may be diffuse or localized, the extent of the hepatic division, the peritoneal or distant disease, the involvement of the lymph nodes. If the gallbladder is showing the jam-packed gallbladder, means it's the filling of the entire gallbladder lumen with the tumor. Patients who are having the chronic cholecystitis and underwent the multi-slice spiral CT scan. The findings of the disruption gallbladder mucosa line, the blurred gallbladder outline, the higher obstruction of the biliary tract, lymphadenopathy, adjacent invasion, the peritoneal effusion, wall nodules, and the gallbladder wall thickening were greater in the patient with the chronic with the gallbladder carcinoma than in the patient with the chronic cholecystitis. Here is the picture showing the mass in the gallbladder fossa. The another CT scan image showing the CA gallbladder with infiltration into the liver. The another picture of the CT scan showing the diffuse wall thickening in the patient with the CA gallbladder. So this slide is showing the CT scan imaging and the TNM classification. The stage 1 is the T1 M0 N0 and it's a in situ carcinoma. The stage 2 is the T2 N0 M0 and here is a mucosal and the muscular invasion. The T3 stage 3 A is the T3 N0 M0 and the transmural direct liver invasion, and the stage 3B is the T3 N1 and M0. The stage 4A is T4N0 M0 or the T4N1 M0. There is a lymph node metastasis, and the stage 4B is a NET N2 M0 and there is a distant metastasis. Another useful investigation is the MRCP. Magnetic resonance cholangiopancreatography can help in assess the disease extent more accurately and properly. It's also identify the unresectable surgical candidates with the hepatoduodenal ligament invasion, vascular enhancement, or the lymph node involvement. So here are the different MRI imaging showing the mass and the fundus of the gallbladder. Now come to the treatment of the CA gallbladder. The standard treatment for the CA gallbladder is surgical resection of the gallbladder cancer, included the extended cholecystectomy with the marginal hepatectomy with the regional lymphadenectomy or the common bile duct resection. But in some cases, gallbladder cancer incidentally found in a cholecystectomy, the pathological specimen with the stage T2 or a higher, the recommendation is to return for the further exploration and the resection. Post-operative chemotherapy should be offered within the 8 to 12 weeks after the extended cholecystectomy, but it requires the baseline laboratory investigation and imaging to restage the disease before the therapy initiation. Adjuvant therapy should be offered to the patient with the resected pathological specimen report of T2 or a higher, node positive, and the margin positive, at least for 6 month adjuvant chemotherapy or alternatively 4 months with the concurrent adjuvant chemo radiation. If you are following the 6 month regime, so you have to do the chemotherapy with gemcitabine or 5-fluorouracil. And in addition to the above, another regimen for 4 cycles of the capecitabine, which is followed by the chemoradiation. Unresectable, locally advanced, and the metastatic gallbladder cancers are the candidates for the palliative goals or the chemotherapy. Local advanced may be managed with the external beam radiation therapy and usually involves a radiosensitizer such as 5-fluorouracil, but these goals are not very effective goals. So what do you think about the prognosis? The gallbladder cancers has a higher risk recurrence rate and the poor prognosis 5-year survival rate. What can be the complications of CA gallbladder? Patient may have obstructive jaundice, the visceral pain, the weight loss, and the tumor recurrence. I will explain the extended cholecystectomy or the surgical point of view of the CA gallbladder in the next video.